Welcome. Um, I'm pleased to present Shelby Brown and Quinn Stein. But first of all, I'd like to remind all the audiences in the remote sites to please mute so that we don't get feedback. Well, we're very pleased that I'm very pleased to introduce Shelby Brown. We've been lucky enough to have her as a pediatric genetic counselor since 2016, and many of you may know her. She is originally from Nevada and graduated from the University of Arkansas for Medical Sciences and received a master's in genetic counseling. And her her talk on Genesurance was submitted to both the National Society of Genetic Counselors, their national meeting, as well as the American College of Medical Genetics. And just out of training, they were both accepted for platform presentations. So I'm sure she'll be using some of this in the talk today. And then also Quinn Stein, who many of you may know. He's been here since 2000, and he's really accomplished a lot, which you may know. First of all, he was successful in getting genetic counselors certified by the Board of Medical and Osteopathic Examiners, so he's lucky enough to have license 0001. And he is now an associate professor of Augustana College and is directing the new genetic counseling program, and also is a clinical professor at the University of South Dakota. And also we're honored that he was selected as the president in the National Society of Genetic Counselors. He's also served as on the board of directors and received the Strategic Leader Award in 2016.
All right, thank you very much, and thank you for inviting me to give Pediatric Grand Round this morning. It's fun to be here, and I know this isn't a conventional topic. It's a little bit different, and I'll kind of tell you how we got to this point. So I'm going to lead it off. Shelby's going to talk in the middle, and then I'll finish this up again today too. So many of you likely know that as a genetic counselor, when we see patients, we talk about things like family history and genetic testing, find an appropriate lab, talk with the family about what's the best test, what the diagnosis means, and give them resources. But frequently, we find ourselves having insurance conversations with the patient as a variable in their decision making of if they want to pursue a possible test or not. And our involvement seems to look something like this. We visit with the patient, we assist with ordering the test you want from the laboratory. The laboratory bills the patient's insurance company. The insurance company determines the deductibles, co-pays, out-of-pocket costs, out-of-pocket max. The insurance company gets that back, pays the testing company what they deem they should. The laboratory then bills the rest to the patient, and the patient pays the laboratory. So like many areas of medicine, it's a little complicated, but we tend to find ourselves involved a little bit more than most. So how did we get here, and what's the current status? You look at this picture for a little bit, think what it might be. Those of you who attend national meetings once in a while might realize this is a trade show, your exhibit hall before it's set up, and once it's all set up, it might look like this, with people with fancy suits, nicer than any I own, greeting you and selling or attempting to tell you why their genetic testing product is great. They'll woo you over, and you can get your professional headshot taken for your own personal use. They may wine and dine you or invite you to dueling pianos as a thank you for your customer service. They may give you T-shirts and pens and everything else. And may even, there's a lot of jobs out there right now for genetic counselors, including in the genetic testing industry. And so they may even say, you know, your clinical experience is great. Would you mind coming and working for us? So what I'm kind of saying is genetic testing is kind of a growing and big piece of the medical testing industry. Globally, this industry was estimated to be valued at $6.2 billion globally in 2014 and expected to be valued at $7.4 billion by 2020. So there's a lot of money being spent in terms of genetic testing. Let's bring that back to the clinic. So I've kind of felt like things have changed with the discussions we're having with patients in terms of genetic testing, and 2012 was sort of an example of when I started to feel this. So one lab in particular, this involved non-invasive prenatal testing, wanted our business and said, you know, here's a fact sheet you can give to your patients. And so if your patient has this insurance, there's no upfront fee, we'll bill them later. If they're not able to pay, we have a financial assistance plan. We don't take Medicaid, for example. And so kind of trying to, or we have a self-pay option of $495. And so kind of trying to figure out how this fit into a conversation with the patient and if this was our role. It was something that started about that time. A competing lab, also trying to get our business. Quinn and Jay, understand you're very busy. I want to keep phone contact to a minimum. 2013, evidently lab reps, it was common at least for them to try to contact us directly. As you know, I selected Sanford as my pilot site for our new $235 out-of-pocket max. No upfront billing. Now you have $0 for state Medicaid and $0 for, or $235 for insurance payers. Has your group come to a decision? And so, and they also had clear and simple payment patient options. So they don't look that simple to me, but $200 or less if you fall into these categories. Of course, you have to understand what a EOB is. All invoices from us will be accompanied with the patient assistance letters. This is for in-network, out-of-network, $200 or less if you qualify. Some states prohibit out-of-pocket limits, star, and then if you live in this states, none of this applies. So this was in the prenatal setting. In the ped setting, this also applied. We have labs that will do benefits investigations for us up front, so we tell we send a packet of information with medical records and reason we want to do the test, and they'll work with the insurance company to figure out what the patient would owe. So thank you for choosing Lab X. Based on the information provided, the patient's out-of-pocket max will be $0. And then as you kind of skim this further, you'll notice it says credit card information is required if you live in a few states. And so even when it's $0, we found ourselves having to talk through these scenarios with patients. And then furthermore, even when it's straight and clear, patient sees out-of-pocket max will be $0. Sometimes it still doesn't work. In this particular case, the mom said, I'm having problems getting my son's lab bill covered with insurance. Apparently my insurance company processed and paid for it back in April, but then went back and rejected in June. They responded to Lab X regarding this, and here's kind of the amount. Now the lab is asking us for $18,000 in payment. Who do they call? They called Quinn. You know, we owe $18,000, you know, what's going on here? And so then it takes a lot of time to go back and figure this out and help the patient. And so kind of as a group, our own local Zoolander, Jay Flanagan, says, I feel like I'm taking crazy pills. And he also says one day, I don't feel like I'm a genetic counselor anymore. I feel like I'm a Genesurance counselor. And so that was the first time I had ever heard that word, because he made it up. And so, but it fit. And so I kind of thought about it, like, that's really good, Jay. You know, I wonder if other people are doing this too. And so I sat down and I kind of penciled out a definition, and to me, Genesurance counseling was that portion of our genetic counseling session, whether intentional or not, that is devoted to the topic of money and costs and third-party coverage, especially for genetic testing. And then I thought, boy, it would really be good if we had a student somewhere, somehow, who wanted to talk about this. And one fell from the sky and was interested in doing this. And so not only has she taken on this project and given platform presentations, but she had her very first journal publication published this week. It went online first on Monday in the Journal of Genetic Counseling, and so she's going to talk about all the work I made her do and nagged. So we'll have her come up, and then I'll talk about 2 other studies that have been done after that. So.
Thank you. The first time I heard about Genesurance is when Quinn introduced that definition to me, and I said, "You're kidding. You want me to do my master's thesis on a term you just made up?" But I graduated, and you guys are fortunate because you trained me, so you had to hire me, right? Well, I want to talk a little bit more about this study. This study we really put together to get a consensus across the genetic counseling field. Is this something that's truly occurring, or is this something my supervisors just made up? What is it between specialties? Is there a difference between the prenatal field versus the pediatric field and even the cancer setting? And how is this conversation affecting our patient relationships? Does it influence our clinical practice? And what are the genetic counselor's perspectives on this topic? So overall, I sent out a survey of 29 questions to the National Society of Genetic Counselors, and we specifically targeted those clinical genetic counselors, so genetic counselors who saw patients on a regular basis. We got a total of 571 responses. Of those responses, 96% were clinical, and that's the data we analyzed. Overall, you can see we had a great turnout. We had genetic counselors from every specialty: prenatal, cancer, even the less common ones or the newer ones like cardio, neurology, teratology. We had a range of years, so some genetic counselors had only been practicing a few months, others had been practicing over 10 years, and we also assessed the patients they saw. So they saw patients with Medicare, Medicaid, and private insurance. Really, the question is this occurring in clinic? And over 99% of counselors said yes, this conversation is actually occurring. Well, if it's occurring, is it important? And 86% agreed that this is an important topic to talk to patients about, to give them that opportunity to make an informed decision. So now that we know it's important, it's occurring, well, is it part of our job? And 84% of genetic counselors, or 85%, agreed that it is our responsibility or our role or some part of our job description. So looking at it, how much time are we spending on this? We know it's occurring, we know we think it's important. On average, the genetic counselor estimates they spend 12% of their genetic counseling session devoted to this topic. That equates to about 8 minutes per session. And then outside of the session, it's about 4.5 hours a week. 58% believed, again, this was their role or responsibility. But if we look back in time, what was this responsibility 3 years ago? Thinking back that far for those who had more experience, they thought they were spending about 8.5% of a counseling session on this topic, which equates to about 5.5 minutes. So you can see it has really increased with time. The more labs we have, the more tests we have to offer, we are spending more time on this topic. So from this survey, we've actually pulled quite a few quotes. Like I said, with 571 respondents and 29 multiple choice questions and free response questions, individuals had a lot to say. I won't read this whole quote to you, but it highlights that time is being spent researching these labs, making sure we're offering it, and deciding more based on a patient's insurance what lab we go with. So as this quote highlights, I'm seeing many more patients now, and the complexity of the options for testing has increased significantly. We have to spend a lot of time researching, is this in-network, out-of-network, what is the coverage, what is the out-of-pocket cost, and many patients don't necessarily understand that themselves, and it's hard to distinguish an EOB from an actual bill. So from the 571 participants, I categorized them in 4 different categories, 3 of which are the main specialties in genetics right now: cancer, prenatal, and pediatrics. The other category consists of cardiology, neurology, nephrology, all those other smaller subspecialties in genetics. So this is a table that highlights those responses, and I really want to target in on the in-session portion. So when we looked at all of those specialties and how much time they were spending, everyone was spending the same portion of a genetic counseling session on this topic. But when we broke it down into time, that's where we see the difference. We know that each genetic counseling session is unique. Some prenatal sessions may be shorter in time, pediatric sessions may be longer in time, but looking at that, we did find a significance with prenatal counselors spending the least amount of time on this topic. So you can see they spent 5 minutes compared to the other specialties. And then again, looking at the out of session, this is where we saw a big significant difference as well. Of all those specialties, the pediatric specialty and the other specialty spent significantly more time outside of a genetic counseling session doing those prior authorizations, those letters of medical necessity, appeals, peer-to-peers, and that was again significant. So laboratories are not billing how they used to bill. I think we have all come to recognize that often laboratories are running testing and then months later coming back to you asking to reopen the chart, to fish out clinical notes, write letters. This is all, again, time consuming. After you've closed a case and you've done the testing and in some cases even gotten the results, you have to go back in and open this up. This is a response from a counselor who started in 2015, and she stated that an issue that seems to come up a lot is the EOB and receiving that bill where the patients feel they have to pay the entire thing. Like Quinn said, that's where you get that phone call from an angry parent. I thought we prior auth this. This wasn't the amount we talked about. What is this? And it makes it very difficult to explain an EOB versus an actual bill. Again, looking back on those genetic counseling specialties and breaking it down to which genetic counselors truly thought it was their job description. It was the cancer genetic counselors that felt the most that this was their responsibility or their role. I feel that Genesurance counseling can be done very efficiently by separating the genetic counselors from the billing entity. And I think this is something that we strive for, but in the midst of this, we can always get caught up with when the patient asks questions, well, how much does it cost? Well, then, have you met your deductible this year? There's a lot of factors that go into it. This conversation does have an impact on rapport. 62% of respondents felt that Genesurance counseling impacted it, not just in a negative or a positive influence, but in one way or the other. There were no significant differences between the specialties and rapport, but of note, the cancer genetic counselors felt strongly that it was a positive impact. And the prenatal genetic counselors were the group that most felt it was a negative impact on rapport, and I can come back to this. So some other quotes I wanted to highlight. I think this tends to decrease trust in me and my motives, sometimes especially with the less medical insurance savvy patients. We're discussing critical things or important things to a family, and then when the topic of finances comes up or paying for something, it can sort of take away from that medical discussion you're having. I feel that it can harm our rapport with patients when we start talking about out-of-pocket costs, explaining to them and answering the questions that the lab asks. So a lot of times the lab will reduce a cost for a patient if we give them how many individuals in the household, what's the gross income. Sometimes that feels like inappropriate questions for a medical provider to be asking. Unfortunately, I think Genesurance counseling sometimes changes the relationship between the genetic counselor and the patient by putting the genetic counselor in an awkward position of discussing money again in that clinical setting. Throughout this survey and reading all of these responses, a lot of individuals felt as though they were selling something. And this individual said, often discussing financial responsibility makes me feel like I'm selling a product to the patient rather than facilitating an informed decision. When I started talking about the different lab options and testing options, I feel as a used car salesman. And then this last one, this individual had a supervisor who got a complaint that they actually felt like they were being sold a genetic test instead of offered a genetic test. So you can see definitely there are feelings of how this can affect rapport. Overall, 95% of genetic counselors who responded to this said that it has some influence over their patient's decision to pursue genetic testing or not. So we know that this is an important topic to discuss with our patients. And actually, it's one that we think is financially toxic. So just like someone can have a side effect to chemotherapy, and you discuss that side effect with the patient, bills can also have an impact on a patient's well-being. They might not be able to afford their household items or pay their monthly bills. So these are all things that should be discussed with a patient because those two are side effects. So moving forward, patients have higher deductibles now, less coverage, and are more concerned about the out-of-pocket costs than they used to be. We often saw if a test was recommended, the patients would quickly do it or consider it. But now a lot has come into this decision, and financial responsibility is one of those factors. In that clinical practice, 74 said yes, they did feel like insurance-related issues changed their practice, and what we saw from respondents was this could delay a send-off or delay getting that testing to make sure we have that prior authorization. Some additional quotes: insurance guides what lab we use, what test we order, who needs pre-authorization, etc. Unfortunately, it's often not the patient's medical and family history that's directing us towards a lab test, but actually the details of their insurance plan. And then this individual highlights that they often do delay send-off, needing to check with insurance. So when does this Genesurance counseling occur? And there is a slight difference between specialties. All the specialties said that it often occurs before the patient makes a decision, but I wanted to highlight with this slide, prenatal genetic counselors were more likely to counsel after a patient's made a decision regarding testing, and this might be due to clinic flow or finding an ultrasound finding and making that decision and then learning the cost after that. So there are a lot of factors between specialties that can change when we have this conversation. Another important topic is cost containment. With our healthcare system now, who is determining if this is cost appropriate and is trying to contain healthcare costs really the responsibility of the genetic counselor. Of those surveyed, the majority felt this was. We also asked genetic counselors to decide or rank themselves between a patient advocate and a cost saver. So a patient advocate, always advocating for that patient for the testing, and then a cost saver only advocating cost-wise when it was necessary. You can see that genetic counselors really fell in between, so they strive to be both that patient advocate and that cost saver. Overall, 32% of respondents acknowledged having some help in their clinic with the prior authorizations or with this Genesurance topic, but nearly 50% of the genetic counselors report spending more time on this than they first began. So again, patients come in more aware of their insurance issues in general and are asking more or better questions. I've also noticed that genetic counselors have frequently gaining a reputation as a resource for all of these questions. It's not that it's a particularly difficult concept to grasp, but it is time consuming, and other clinic providers might not necessarily have that time or are not willing to discuss all of those topics with them. The patient finance department at this individual's hospital is less comfortable with these issues because, as noted, these labs are changing constantly and the prices are changing. I'm asked to identify labs, codes, pre-authorizations, etc. It seems to take much longer to prior auth and make sure that a procedure is covered benefit. There are many more layers to insurance than before, and again, it's a difficult concept to understand. So I must constantly be aware of what labs take what insurance. As this person highlights, they can change, and these aspects can even change while you're sending a sample to the lab. And I think it's a very frustrating thing to have to call a patient back and say we actually have to do a redraw and send to a different lab because the one we were sending to changed their policy in the meantime. So this is a triangle effect that I put in, and thinking about this from the beginning when I started this, yes, genetic counselors are right in the middle. We're helping those patients, and we're contacting insurance, and we're working with the labs. But then the longer I did this thesis, and maybe I'm just biased because I was up all night working on this for many years, I feel like we're just pinched. We're pinched in the middle. We're trying to work with that patient to get that insurance approval. But even if we get an approval, the patient could still have a cost. We don't know exactly if they've met their deductible or what that out-of-pocket cost may be. And then again, we're working with those labs to come up with a contracted price or something that can benefit the patient to reduce that cost. So we have a lot of people we're working with and trying to get the best answers for that patient to get them the testing that they need. So again, just some more quotes, and again, there are a lot of quotes throughout this. I won't go through them all, but some final thoughts to leave you with before Quinn comes back and tells you more of the other studies. Some genetic counselors highlighted a few important points. I wasn't trained to address these questions. Maybe we can have more training on insurance and what it means. I know the Augustana Sanford program has done a great job incorporating this into their program and training. It sometimes concerns me that no other medical provider discusses costs. I'm not sure that the genetic counselors should be either. I'm not overly concerned, but sometimes wonder about the liability associated with my providing financial counseling. And I think what this prompted most in me is to think, how often do I go to my primary care physician and ask, well, what does a CDC cost? Or is this going to be improved by my insurance? It just made me more educated in knowing the cost of medical procedures. And lastly, it's become a barrier to appropriate care. We're not always able to get individuals the testing that they need. We can have two individuals with the same symptoms and the same presentation, and only one of them we can get testing for because of their insurance coverage. So, thank you.
All right, so talk about a couple other studies as we finish up my part. And so Shelby taking this on and the survey that she did prompted a couple other students to contact her or me and want to get involved in this area too. So one from UT Houston and one from UC Irvine. So I'm going to talk about each of those. And the first one is, so as Shelby alluded to, we're finding ourselves having these Genesurance conversations with patients, and we don't really want to, but we found ourselves in that space. And part of it just seems that it's a piece of decision making for the patient, and so I think that's how we ended up there. But we wondered, what do patients expect from us? Are they expecting different from us, or are we just giving them something they don't want? And so Chelsea Wagner from UT Houston took on this particular project, and her question was, what do patients expect from genetic counselors in regard to the discussion of insurance coverage and genetic tests during a session? She also did a lot with health insurance literacy too. We're not going to cover that portion today. And as we've mentioned, the price of a genetic test isn't as simple as, like most labs, this is the cost. It may or may not be covered. There's so many other factors that come into play. And so partially based on what Shelby did, she came up with a 38-item survey that was kind of fun to put together. We used 4 Sanford Health sites, Sioux Falls, Fargo, Bemidji, and Bismarck, and multiple sites in the Houston area as well. And patients were giving a survey on their expectations prior to meeting with the genetic counselor. These were in the pediatric and prenatal settings. They were not, I'm sorry, they were in the prenatal and cancer settings. We did not do this specifically in the pediatric setting. And her goal was 300 to be significant, and we surpassed that. And then we compared her demographics to see if we were representing the population. And we asked the patient, you know, are you here for a prenatal or cancer appointment, or don't you know? 12% didn't know why they were there. Fortunately, most of those were in Houston. We looked back, we were afraid of us. Very nicely, we couldn't have accomplished this if we just used the Dakotas and Minnesota, but our ethnicity demographics did mirror the makeup of the United States. Household income perhaps did not, but we did have a large distribution of income. Quarter of people in our survey did make over $100,000 a year, and they just explained this as the makeup of some of the clinics in Houston. And about a quarter of our people in our survey had public insurance, such as Medicaid, and 3/4 had private insurance. So we were hoping we would ask the patients, what do you expect from the genetic counselor? And that they would say, we don't expect you to talk about Genesurance or these topics at all. Fortunately, that's not what we found. 83% of our patients did say that they provide or expected the genetic counselor to provide an estimate of their out-of-pocket max. 82% expected us to know if it was a covered benefit for them. And 80% expected us to discuss this during their genetic counseling appointment. Those are possibly realistic. We have some idealistic, possibly unrealistic expectations too, such as know each person's individual policy information or provide an exact amount of what this would cost. And so Chelsea shot down everything we had hoped, that we weren't responsible for this. We also asked who is responsible, and they could select more than one answer. They could say the genetic counselor and themselves and someone else. But at the top of the list was the genetic counselor. Of course, there could be some bias because they got this before they were seeing us, but that was a high number. Second only to that, though, was themselves. So they did expect, they did put responsibility on themselves for this too. And lower down the list was physicians. So they are thinking differently about physicians and genetic counselors. And then a small number even expected to have this discussion with the laboratory. So how can we address this? Perhaps we can give them list prices, billing support, or online tools. In terms of knowing if it's a covered benefit, there are national guidelines in prenatal and cancer we can follow. It's a little less clear in pediatrics. We can certainly provide them contact information for the right people with certain questions. And then perhaps using visual aids or providing them with CPT codes if we know them, you know, to say, here is the CPT code for the lab patient, you know, contact and see if this is covered and take the burden off ourselves. What about those idealistic things? Well, certainly it's not possible to have a working knowledge of each person's insurance plan and coverage. Even if we just thought about Sanford Health Plan, the plan at Augustana looks different than the plan that Sanford employees have. So we can't just even go by that. So that's really just not possible. And certainly we can't provide an out-of-pocket max. We don't know what their deductible is, nor should we, and we feel that's out of our realm. When do the patient, you heard Shelby say some prenatal counselors bring this up after a decision has been made about a test. Most bring it up before. When do patients want to talk about this? Well, as you would expect, most patients want to talk about it before a decision is made. They want these topics of cost to come up as part of their decision making. So what is it about this genetic exceptionalism? We don't know. We don't know why they expect more of genetic counselors and of talking about prices for genetic tests more than CBCs or x-rays or your appointment with an orthopedic surgeon. But patients are expecting insurance-related topics to be discussed in genetic counseling sessions at a much greater rate than what they expect of their physicians. So good news for you physicians. Like Shelby, Chelsea had a lot of spots for open-ended questions, and 3 themes that emerged were personal responsibility. As one, my provider doesn't know the plan coverage I have, and it's my responsibility to find out by calling the insurance company to find out if a procedure or testing is covered. That's one theme. Second theme is provider responsibility. I believe any provider should advise patients to contact their insurance provider to discuss coverage, as some tests may or may not be recovered. And then a third theme was shared responsibility. I believe I should ask questions about my coverage, but at the same time, this is all new to me, and it is a lot of information to take in. And so she further broke it down into other themes, and I'll leave this up for just a couple seconds so you can read a few more of those. And so we're kind of realizing our theme from her study was patient expectations. Just like our patients are expecting personalized medicine, they seem to be expecting personalized insurance conversations as well. So conclusions from her study seem to be patients want to have these Genesurance discussions, but they also believe they are partially responsible for it. Perhaps this highlights an opportunity for visual aids or easy to understand cards or web portals, and also a chance to address efficiency in the clinic. You know, how can we make this faster? Are there videos we can create? Possible other things we can do based on, or to take some of that burden off the genetic counselor and have that time be spent on other issues. And then the last thing I'm going to highlight is this other study we did based out of UC Irvine, which was another national survey of genetic counselors. This had a smaller sample size than Shelby's, and so not a lot of statistical significance, but some things that are interesting. And what Molly and our team wanted to look at was to characterize the interaction counselors are having with insurance coverage. What training did we receive? And then compare that to confidence and how well prepared we were. Similar to Shelby, she found that about 14% of a session was devoted to the Genesurance topic. And that's in a session. Looking outside of a session, again, similar to Shelby, the most or the highest percentage of people are spending 1 to 5 hours, but there are people spending more than 5 hours in their clinic as well. An interesting additional thing she asked was institutional billing versus direct lab billing. So some of you may or may not know, in some genetic testing labs have kits, so you kind of bypass your own hospital lab, and so you fill out the paperwork for the lab, you get a blood draw, or you can do a saliva sample or a cheek swab right in your office, put that all in the kit along with insurance information, and the lab handles all of that. Versus institutional billing, where traditionally you put in the order into Epic, it goes to the reference lab here, institutional lab, they send it out, comes back to the institution, and then billing works that way. I don't want to advocate for one or the other at all today, that's a different topic, but 84% of counselors are using lab billing, like those kits I mentioned, at least sometime. Compare that to institutional billing. About there are only 44% of so there is a difference between institutional and direct lab billing, and we do use both. So just going to point out kind of one thing here. So do you use institutional billing? If the answer is yes, you're more likely to be spending more than 5 hours a week. So this is a busy slide, but institutional billing does take more time than it does when you fill out paperwork and send it directly to the lab, because the lab is trying to get your business that way, and they're taking care of that, and it cuts time. So think about this scenario as we finish up, and this could apply for any of us. This was a scenario that Molly put out as part of her survey. So you order a chromosome microarray for a 5-year-old diagnosed with autism. You indicate on the test requisition form that the laboratory should bill the insurance company on that patient's behalf. You believe the test is medically necessary and fulfills the policy for testing. However, it's denied. So what are you going to do next when this is denied out of these options? Are you going to do nothing? Going to appeal? You're going to contact the insurance company? Are you going to contact the lab? Are you going to put the onus on the patient? So when Molly asked the genetic counselors, what are you going to do? Probably similar to what most pediatricians would do. We're going to get involved ourselves instead of asking the lab. So the majority were appeal, contact lab, or contact insurance company. Very few people as a percentage would put the onus back on the patient. So we're taking that back on. Additionally, the majority of respondents who selected pediatric as their subspecialty reported the next step they would do is they would just jump right in and appeal on the behalf. This differed from the other specialties who said the next best step would be to contact the lab. So I think this comes back to how we're using institutional and direct billing, because looking at this slide, if you're in pediatrics, 56%, as I just said, are going to appeal right away. If you're not pediatric, you're going to contact the lab, meaning you're using those kits. And so, no surprise to the pediatric genetic counselors, 94% of cancer counselors are using the direct laboratory billing, but the pediatric counselors are using that institutional billing. All this makes sense as I've thought about it, and go back to Shelby's study and say the pediatric genetic counselors are spending the most most time outside of clinic sessions. They're also using institutional billing, and institutional billing is taking more time. So I think that's kind of interesting connection. Also, what about training and programs? Are we talking to our students or are we preparing our students to know how to get involved? Well, if you graduated less than 2 years ago, very good chance you received this training. And incrementally, you can see, 10 years ago, less than a quarter, and so forth. And this was significant. In just kind of a graph showing the same thing, that if you graduated recently, you received training. If you graduated a long time ago, you did not receive training. And then if you received training, did that make you more confident? Yes, for the most part. If you add the two blue bars together, you tend to be more confident and feel more prepared, as you would expect. If you did not receive any training, there was greater than an 80% chance that you didn't feel very prepared to take this on. So it's a small part of what we talk about in the genetic counseling program, but we do talk about it. We have a course that this is a small part of called Genomics and Business. It's one of my most fun classes that I teach, and we do this every other year. In addition to topics like this, we do more fun stuff like media training and public policy and business development and industry kind of topics. So that's been a fun class. So is this going away? No, it's getting worse. Insurance companies are now starting to use automated prior authorization systems. Blue Cross Blue Shield is using a group called AIM. United Healthcare has its own more complicated system. So what does this mean? Well, for somebody, this is going to mean more hours outside of clinic. I don't know if that's us. I don't know if that's the a billing lab rep. Shelby mentioned 32% of genetic counselors have help in their clinic to work with these issues, meaning a lot of people do not. We're lucky at Sanford in many places that we do have the help, but we don't have it everywhere, and certainly across the country we don't. So this is a topic that is a little different. Definitely hit a nerve with a lot of genetic counselors across the country as we realize this is a part of our practice. And maybe you knew we were having these discussions with patients, and maybe you did not, but now you all know. And so Megan Bell, Jay Flanagan, Susan Pumala, Jen Leonard, and Lori Dean did a lot of work on Shelby's project. And then also want to acknowledge Chelsea and Molly for letting me present part of their work today. So we were supposed to finish at 8:45. We did good. All right. Thank you. We'd be happy to take questions if you even know what to ask.